Hi everyone, I am going to present my project with the topic Clinical Practice Guideline for Managing Chronic Non-Cancer Pain in Adults in Primary Care Setting, an Integrated Algorithmic Approach. My name is Cynthia Ameshie. My chairperson is Dr. Snell, and my second reader is Dr. Rita Wonderlick, and my committee member is Dr. Charles Payne II. Background and significance. The purpose of this clinical practice guideline is to effectively manage chronic non-cancer pain in adults in primary care setting. This involves using both pharmacological and pharmacological interventions to inform clinical decision based on evidence-based practice recommendations. As we all know, clinical practice guidelines can be valuable tools to guide primary care in selecting pain care treatments based on the available evidence. In Ohio and Cleveland, primary care clinicians play a central role in pain management, as most opioid prescriptions originate in outpatient primary care settings. Healthcare providers frequently treat patients with chronic musculoskeletal and neuropathic pain, complicated by mental health issues and socioeconomic challenges. Furthermore, variety in practice persists despite state and national guidelines, particularly in opioid prescribing, non-pharmacological therapies, and patient-centered care. These challenges underscore the need for a standardized, evidence-based approach towards clinical decision, which can lead to improved functionality and quality of life for the patient. Literature review. This project was characterized as non-intervention initiative focused on developing a clinical practice guideline, managing chronic non-cancer pain. Systematic data collection and analysis were employed to evaluate the quality of work against established clinical practice guidelines. And the guidelines drew upon evidence from both primary and secondary sources. Keywords: chronic non-cancer pain, clinical practice guideline, and systematic review. Clinical success should be evaluated by improvement in daily function and quality of life rather than complete elimination of pain or pain elimination. Emphasis: a holistic assessment and the patient-provider relationship. A multimodal biopsychosocial approach should prioritize non-pharmacological therapies over the long-term use of opiates. Also, pharmacological management with the use of non-opioid as first line and opioids as a last resort, including prescribing protocols. Multidisciplinary approach or teamwork, including involvement of physical therapists, psychologists, psychiatrists, and pain management specialists. Theoretical framework. The theoretical framework was grounded in the biopsychosocial model. The module shifts the focus from treating pain from the biomedical standpoint, rather as a complex interplay of physical, psychological, and social factors. The key strategies built into this framework and clinical translation in primary care include patient-centered goal setting, focusing on restoring function and improving the quality of life, non-pharmacological management, including CBT, pharmacological management, by solely relying on opioids due to long-term safety concerns and as an adjunct to other therapies. Self-management by empowering patients through education and practical self-care skills, and also interdisciplinary approach. Method and design. So the setting took place in a primary care in Cleveland, Ohio, operating in 4 locations, seeing about 300 patients in all 4 locations, with chronic condition and pain as well. Chronic pain as well. Yeah. So this was the formula that was used to calculate the results. The minimum and the maximum possible scores were then used to calculate the skill domain quality scores. Using the following equation, obtain domain total minus minimum possible score over maximum possible score minus minimum possible score times 100. The main risk is the time commitment required from appraisers to provide feedback. Therefore, I ensured by addressing that. Therefore, I addressed this by ensuring that reviewers understand the project and participation were voluntarily without coercion or fear of retaliation. No health information was collected, eliminating any risk of violating the HIPAA privacy rule. Okay. The project does not involve human subjects, so informed consent has been waived, and no measures are needed to ensure anonymity and confidentiality. In summary, the benefits of standardizing care and improving function and quality of life for adults with chronic non-cancer pain can far exceed any minimal risks involved in this project. Sample. So the clinic has a team of 8 healthcare providers, all specializing in primary care. They consist of 2 physicians and 6 nurse practitioners. As I mentioned earlier on, no subjects were involved. And this project was aimed to, the data analysis. This project was aimed to identify appraisers and solicit reviewers of clinical practice guidelines using the agreed-to instrument. All individuals who reviewed the clinical practice guidelines were 8. 70, and it stands for 100%, or on a percentage level. 75% were nurse practitioners, which were 6, and 25% of the appraisers were physicians, all working in primary care. All appraisers manage patients with chronic non-cancer pain. Figure 1 shows the role of stakeholders who evaluated the clinical practice guideline using the agreed-to instrument. So this is the healthcare roles in stakeholders. All right. So this was a percentage of number of people who took who appraised the tool, with 25% representing physician and 75% representing nurse practitioners. The next figure shows the number of items per domain, and the domain were 6. So these are the number of items per each domain. and it's explained below. The third figure compares the maximum possible points for each domain with the total points awarded by the 8 appraisers. So these are the total points to total points awarded by appraisers. Okay. The ordinal data from the agreed to instrument were analyzed according to its guideline. An appraiser assigned scores to 23 items on a 7-point scale, ranging from 1 meaning strong disagreement to 7 strong agreement. These items were grouped into 6 domains, and the total score for each domain was calculated by summing the scores within that domain. The domain total were then combined to create overall score based on evaluation from all 8 appraisers. I also set a threshold of 85% or higher for all domains. A scale domain score below the limit indicates weakness in the clinical practice guideline, while a higher score suggests rigor or reliability. So the lowest score recorded after initial feedback was 99.5%, confirming the guideline's strength. The agreed instrument included a 7-point scale for appraisers to assess overall quality, and also a final question collecting appraisers' guideline recommendation. So let me go back. So this is the table that shows the domain quality score, minimum possible total score, and its values. And the maximum possible total were in this column right here. Domain total were all recorded in this column, and the scale domain score in percentage was recorded in this column. All right. And this is the table showing overall score by each appraiser. It was 8 of them. And overall guidelines quantity, everybody gave a score of 7, showing the highest possible quality. And also all of them said yes. There were questions which says yes, or yes with modification, or no, and all appraisers agreed saying yes, they were going to adopt the guidelines at the selected facility without modification. So these were all the results. Everybody said yes, they were going to recommend the use of the guidelines. Okay, so moving on. So the guidelines was formulated based on themes identified during the literature review, which centers on the management of chronic non-cancer pain. It encompasses both pharmacological and non-pharmacological treatments. After the development of the clinical practice guideline, upon confirming that it met the requisite strength criteria, it was finalized and presented to the team and leadership for approval and accepted into practice. Limitations. So some of the limitations encountered were vagueness of recommendation from some of the guidelines reviewed, exclusion of valuable but short-term randomized controlled trials without any meta-analysis, resulting in an incomplete picture, treatment efficacy and adverse effect, and also heterogeneity of the chronic non-cancer pain. Discussion. Clinical significance. This clinical guidelines aims to create an evidence-based algorithm for quick reference on treatment options and using evidence-based clinical decision making. It focuses on identifying patients with psychological conditions and chronic non-cancer pain, ensuring they receive suitable pharmacological and non-pharmacological interventions. Barriers. A key issue with this project was limited time in the primary care setting due to providers' busy schedules and varying patient appointment times. So that could have interfered with assessment of the tool. Facilitated. So the key advantage of the project design included eliminating the requirement for informed consent and protecting confidentiality given the absence of participants. Unintended consequences. While the primary objective of this guideline is to standardize care, minimize opioid-related risks, and advocate for a holistic approach to health, evidence from real-world scenarios reveal negative spillover effect. Also, rapid tapering dictated by strict clinical guidelines can lead to abrupt medication discontinuation, causing severe withdrawal symptoms, psychological distress, and also a higher risk of suicide. Also, even though there were options for alternative therapies, most insurance will not pay for non-pharmacological therapies such as cognitive behavioral therapy or other therapies that will be available. Implication for practice. The implementation of this project is anticipated to improve healthcare providers' workflow by reducing reliance on manual chart reviews. It also will see to patient education and self-management strategies from nurses, also to facilitate effective medication monitoring through routine pill counts, urine drug screening to make sure there is compliance and avoid diversion, and also evaluation of possible adverse effects associated with pharmacotherapy. Also, it will help address racial disparities in referrals and prescribing practices for chronic pain management, and also improving equitable healthcare outcomes. So, conclusions. The project concluded that a multimodal, person-centered approach prioritizes evidence-based non-pharmacological interventions. It also emphasized the importance of structured prescribing for opioids and non-opioid medications, incorporating risk stratification, and regular assessment of treatment outcomes. Finally, ongoing provider education on the social and psychological aspects of chronic non-cancer pain is essential for building empathic, trust-based relationship with patients. All right. The impact of the project. So the impact of this project has increased my colleagues' confidence in using the algorithm in managing chronic non-cancer pain. Prior to that, there was this confusion of using just the opioid or pharmacological therapy alone, and now we are including non-pharmacological intervention as well. And now the non-pharmacological intervention is the first line instead, and then the second line will be the pharmacological aspect. We are also including interdisciplinary team to help manage these individuals. In the future, research into chronic non-cancer pain focusing on non-opioid analgesics, cannabinoids, neuromodulation techniques, and personalized non-pharmacological treatments like nutrition and cognitive therapies. Okay. The personal impact of the DNP program on me as an individual and a student is that this program helped turn me into a transformational leader with a unified vision and empowering my teams. Also, it has helped me to close the gap in practice using evidence-based practice in my clinical decisions. Also, being able to navigate legislative framework to impact public health outcomes. And finally, a shift of focus from treating just an individual patient to now analyzing population health and organizational workflow. And these are all my references used for this PowerPoint. Thank you for listening, and I'm looking forward for your suggestions and any contribution you have towards this project. Thank you for your time.